Today I'll be talking to you about the immunological assessment that we do on our recipients pre and post-transplant. So I have no disclosures. So the topics that we'll be covering today are what we do in the HLA lab in terms of pre-transplant testing for our candidates, peri-transplant, and post-transplant. So to start off with the case, this is a 37-year-old female who's approaching the need for renal replacement therapy and is interested in transplant. She's blood group O, and the HLA typing is as follows. She's had 5 children and a PRA of 85%. Her brother, whose blood group A, is interested in donating to her. He has the following HLA typing. Her friend, whose blood group O, has the following HLA typing. So which one of the following statements is the most correct? You can use your audience response now. Oh, there's no audience response, I'm told. Okay, so this initial case is just to get you thinking about what we're doing in terms of HLA typing, so we'll get back to that afterwards. I do want to tell you that in your syllabus, I did include some extra slides so that to give you some extra background on what I will talk about off the cuff. So there may be some slides that aren't in my talk that you have. So let's start with our pre-transplant evaluation. So the first thing that we want to do is we want to determine the candidate's ABO status. Okay, so as you all know, ABO isoagglutinins are present on red blood cells. But what some people don't realize is they're actually present on a number of different tissue cells, including endothelial and epithelial cells. So actually transplanting across an ABO incompatible barrier can lead to hyperacute rejection. So for example, in our case, we have a blood group O recipient, and one of our potential donors is a blood group A. So if she's blood group O, she has anti-A and anti-B antibodies. And so transplanting across this ABO incompatible barrier is something that we could potentially do, but we would need to do it in conjunction with what we call desensitization, so things like splenectomy or use of rituximab. Now, we used to do this a little bit in the past, but that's fallen out of favor now because a lot of people are utilizing living donor exchange programs, such as the NKR or the National Kidney Registry that you've probably heard about. And of course, that's a lot better because then we don't have to do these extra things in terms of desensitization. One big caveat is the A2 blood group individuals. This is a subtype of the blood group A. They actually express lower density of the A antigen and can be acceptable donors for blood group B recipients that have lower titer anti-A antibodies. And this is important basically because blood group B recipients have twice as long of a wait list as blood group A. So this allows them to potentially get an offer for a kidney much earlier. And if you look at these A2 kidneys into B recipients, you don't actually need to do any degree of desensitization or change their immunosuppression in any way. And they actually have similar graft and patient outcomes when you compare it to B kidneys into B recipients. So let's now move on to determining HLA antigens in our folks. And essentially, this is what the tissue typing lab first does. And it's important in determining organ allocation really on the basis of what we call a zero antigen HLA mismatch. Okay? And really these days with the kidney allocation system, we're only getting points for our pairs if there's a zero antigen mismatch. If there's a 1 antigen mismatch versus a 6 antigen mismatch, there's no sort of extra points for whether you're a 1 mismatch or you're a 6 mismatch. And that's essentially so that we can sort of offer kidneys to everybody, because as you can imagine, if you're in an ethnic minority, your likelihood of getting a very good matched kidney and less mismatch is a lot less likely than you are if you're a Caucasian recipient. So what is HLA? I believe Dr. Azzi probably touched upon this a little bit, but just as a refresher, so it stands for human leukocyte antigen. It's the major histocompatibility complex of humans, and its purpose as the MHC molecule is to present antigens to the T cell. So for example, if any one of us gets a bacterial infection, what happens is the bacteria is processed by our antigen-presenting cells, and a piece of it, known the foreign peptide, is actually presented on our HLA or MHC molecule. And this presentation of both the peptide and the MHC is what the T cell receptors and our T cells recognize as being foreign, and therefore activates the T cell pathway. Now, normally, in the absence of the foreign peptide, we won't elicit a T cell response, okay? And that's what maintains immune homeostasis. However, in the context of transplant, what happens is that if you put in a donor kidney that has an HLA antigen that appears foreign to the recipient, then the T cell receptor can actually recognize that foreign HLA and activate, and T cell activation occurs even in the absence of a foreign peptide, okay? So HLA is divided into class 1 and class 2. Class 1, the A, B, and C loci are present on all, it should say nucleated cells, actually. Whereas class 2, which is the DR, DP, and DQ loci, are present on professional antigen-presenting cells. So meaning dendritic cells, macrophages, and B cells. Okay? So each individual inherits one haplotype or one chromosome, and that's chromosome 6 is where the HLA alleles reside, from each parent with a defined, so there's A, B, and DR are the alleles that we specifically look at in terms of solid organ transplantation. And this came from the historical context where we thought that these A, B, and DR antigens were the most what we call immunogenic. That's not to say that HLA-C, DP, and DQ aren't immunogenic, but they don't cause hyperacute rejection, and their significance in terms of long-term graft survival is still being debated in the literature. So HLA, DR, and B matching does influence short-term survival, and HLA-A is thought to more influence long-term survival. So if the recipient and the donor are siblings and they have the exact same HLAs, that means they're a two haplotype match, meaning that they got the same chromosome from mom and they got the same chromosome from dad. So that happens at about a frequency of 1 in 4, right? Mendelian genetics. If we talk about a 6 antigen match, that refers to just matching at the A, B, and DR loci, regardless of the haplotype. So regardless if they're on the same chromosome. And so you can actually be unrelated and have a 6 antigen match. Okay, so what does it look like in terms of graft survival, in terms of mismatching? So this was the seminal study by Paul Terasaki. And if you focus on looking at this top panel here, what you can see is graft outcome definitely matters if you have more mismatches. So 0 antigen mismatches, you have the best graft outcome, and 6 antigen mismatches, you sort of have the worst. Now, in today's era of modern immunosuppression, that delta and difference between graft survival numbers has shrunk quite a bit. And so these days, as I mentioned, we only give extra points for 0 antigen mismatches, and sort of 1 antigen mismatches is essentially equivalent to 6 antigen mismatches when we're running our match run. So how do we actually do the HLA typing? So historically, and still in some countries around the world, we rely on serological-based testing. And so what we do here is we have a panel of different wells. And these wells are basically serum from a variety of people. And they have antibody that is known to be against class 1 and class 2 antigens. So for example, this orange well would be serum that contains A1, A23, A24, and A66 antibody. And then, so here it is broken down into each well. So this would be the serum that's there. So in this particular case, there's the three different HLA antibodies that's present. And what we do is we add in our patient or recipient lymphocytes, okay? And once we do that, if, for example, this orange antibody is against the A2 antigen, and your patient has the A2 antigen, then that will bind, and when you add complement, that will lead to cell lysis and cytotoxicity, which we detect as a color change, okay? So then what happens is you take the whole panel, and what you get is sort of a pattern. And that pattern of positive wells really determines the typing. But nowadays, at least in the US, most labs have moved towards what are called molecular methods, and this uses the techniques like RT-PCR or next-gen sequencing to actually type HLA. And so with some of these molecular techniques, what you'll get is you'll get a higher degree of resolution, okay? Which means that you will get what the allele group is, and that's what this means, HLA-A star O2, okay? And the allele would be the O201. But essentially in solid organ transplantation, we don't really focus necessarily on allelic differences. What we're most interested in is obviously the antigenic differences, what's going to be sort of expressed on the cell surface of the cells. So a lot of times your HLA lab will translate this into just what the antigenic group is going to be. But as you can see with next-gen sequencing, you can sort of even type down to silent substitutions, which probably doesn't mean anything clinically. So getting back to case 1, I don't know if we want to go over this because we don't have audience response. Just go over it. Okay, so in this case, if you look at her brother typing, the answer here is her brother is a 1 haplotype match and a 1 antigen mismatch, okay? So what I've highlighted in red are sort of the antigens that they share. And so when you're looking at a haplotype match, they should have 1 A antigen that's the same, 1 B antigen that's the same, 1 DP, 1 DQ, and 1 DR. Here I've highlighted 2 of the A's and 2 of the DQs because basically we can't tell which of them are on the same allele, okay? And then there's a 1 antigen mismatch, which is B44. Now when considering mismatches, at least for solid organ transplant, you have to think about directionality, okay? So the way I would think about it is you think about the recipient and you look at the potential donor kidney that's coming into the recipient and you think, is there an HLA antigen that appears foreign? And so the recipient is B42 and B65. So clearly a B44 antigen would be foreign. So that's why there's the 1 antigen and it's a B locus mismatch. Okay, so what about screening for anti-HLA antibodies? Okay, so this is the exact same case, and now all I want to do is highlight further testing that was done by your tissue typing lab. So in this case, we tested for anti-HLA antibodies using a single antigen bead testing, otherwise known as the Luminex assay, and was found to have the antibodies against the following. Okay, so let's talk about how we actually test for that and get back to the answers for this question. So when you talk about pre-existing anti-HLA antibody, that a higher or more more anti-HLA antibody means that you have a higher risk of developing antibody-mediated rejection post-transplant. And it's a general indicator of how much immune sensitization you've had in the past. And so in that sense, it's a way to inform clinicians how we might use induction therapy, how to monitor these patients post-transplant, and the intensity of the immunosuppression that we want to use. Okay? And of course, as we all know, you can get sensitized through pregnancy, transfusion, prior grafts, infection, or vaccination. Screening of the pre-transplant candidate is done in order, as I said, to quantitate the amount of anti-HLA antibodies that are there. And globally, it's then expressed as what we call a PRA, or a panel reactive antibody. Okay? And so you can generally think about it in terms of a high PRA level means that the patient's very highly sensitized and therefore has low likelihood of getting a transplant, right? Because they have a lot of alloantibodies to many different donors. So if you then look at graft survival, it's true, those that are more highly sensitized with high PRA levels, expressed here in the yellow bars, do have lower graft survival rates at the 1, 3, and 5 year mark. Okay? So screening these days depends on the center. Most centers these days do it more on a quarterly basis. And as I mentioned, a high PRA gives you a lower chance of getting an offer for a kidney. So because of that, the kidney allocation system has worked into it what we call a point system. And so handicap points are given for these highly sensitized patients with a high PRA in order to even out their chances for getting an organ. And so they're not being discriminated against. So how is screening done? So there, historically, we used to use with the cytotoxic assay, but more, almost all labs these days are using flow-based Luminex assay. We'll get to that. So this is the cytotoxic assay. So essentially, you've seen the same sort of setup before, but the difference now is that the serum and the lymphocytes are reversed. And what do I mean by that? So now you're actually taking recipient serum. Okay, so these are the recipient anti-HLA antibodies that are residing here, and you add in various donor lymphocytes, okay? And so again, if there's an anti-HLA antibody that's donor-specific, then cell cytotoxicity occurs, okay? And so you would set up like a panel of about 40 different wells. So the recipient serum would be the same in all the different wells, and you would throw in different donor lymphocytes into each of them, okay? And say 10 of them reacted and were positive. Then that would sort of give you a PRA level of 25%. Unfortunately, in this previous testing, antigens of rare frequency are really given as much weight as those that occur commonly. The other difficulty with it is it was very laborious. These panel of cells had to be maintained. It was very challenging because you had to interpret the readout in different ways. And so it really sometimes couldn't tell you exactly which HLA antibody you had. So as I said, everybody's moving towards what we call solid phase assays using flow cytometry. I'll focus mostly on the Luminex single antigen bead assay because that's what most places use. And so using this assay, we now calculate our PRA levels, okay? And how you calculate it, and the calculation is really determining what your likelihood of transplantation is. And you calculate it by first defining the HLA antibodies by this method, and then using this in combination with the known frequency of HLA alleles within the general population. So now you're starting to take into consideration that some antigens are going to be more frequent. Okay? So how does this work? So the Luminex assay, so we utilizes the bead, okay, and each bead is a different color, okay, and there's 100 beads on the same panel, and each of these beads contains one single HLA antigen, okay. So then you throw on the recipient serum, and if they have alloantibodies specifically directed against that particular HLA molecule, binding will occur. You then come in and you use a secondary fluorescently labeled antibody that recognizes this first antibody. And so if that color is now detected, then you know that alloantibody is present. So, and then your specificity of that antibody is determined by knowing what color the bead is. Okay, so this is a very nice assay in order where you can multiplex and do multiple testings. It's extremely sensitive. It's more consistent than the cell-based techniques we just talked about. But there's ongoing clinical debate about this because it's unclear what the clinical significance of these antibodies are that are identified by this highly sensitive test, but not detected by other methods like our cross matches. And we'll get to that subsequently. Okay, so how do I actually calculate the CPRA level? Okay, so let's say we know what the allelic frequencies are of all the different antigens. And here it's just the Caucasian donor frequencies. So as you can see here, A2 is very frequently found in the Caucasian population, 48% in fact. And then you take the recipient serums and you test it through the single antigen bead assay. And if your patient has no antibodies, then their CPRA level is 0%. If your patient, for example, has an A2 antibody, then their CPRA level is 48%, corresponding to the antigenic frequency in your donor population. If they have an A2 and a B44, then it's cumulative. So 48 plus 27, 59%. And so as you can see, it's a better way of actually gauging your likelihood of transplantation based on the donor population that you have at hand. So again, higher the CPRA level, less likely that you will get a match offer, and therefore CAS, the kidney allocation system, gives you extra points for that. Okay? And I think I've already alluded to this. So here's what the actual output looks like if you go down to your tissue typing lab and look at the raw data. So just to orient you, so the y-axis is what we call mean fluorescent intensity. Essentially, it's a semi-quantitative way to tell you about your alloantibody strength or concentration, okay? And so different cutoffs, sorry, I'll back up. So, and then on your x-axis, what you have are all the different beads. So 100 different beads, and what we're looking at here is just the class 1. And each of these histogram bars represents a different bead, and therefore a different antigen. Okay? So as you can see here, this line represents what we call an MFI cutoff of 3,000, which is what most people use in order to define what we call our unacceptable antigens. Antigens to which your recipient has alloantibody. Okay? So therefore, if you list all of these antibodies under UNET, anytime a donor kidney becomes available and they have these particular donor antigens, your recipient will not come up for the match run. Okay? And that's what essentially we want, because we don't want a hyperacute reaction to be occurring. So, but as you can see, some people are sort of pushing the envelope a little bit and thinking maybe we should look and see if we should use lower MFI cutoffs so that we're giving our recipients the best kidneys available, okay? But the problem is, you know, we don't really know if these low-level antibody, even if they're DSA, truly do affect graft outcome. We really don't know what the cutoff is in terms of using this, as I said, semi-quantitative assay. And the flip side of that is, if you start listing so many unacceptable antigens, you're going to be disadvantaging those who are highly sensitized with a lot of alloantibody. Okay? So same sort of thing can be applied for the class 2s as well. So what do I mean by donor-specific antibody? So simplistically thinking, you need to type your donor, figure out what their antigens are. You look at your candidate serum, and these are the 6 anti-HLA antibodies that they have. And as you can see, the only anti-HLA antibody that they have that appears to be a donor antigen is A11. So your conclusion would be that they have 4 class 1 anti-HLA antibodies, 2 class 2 anti-HLA antibodies, but only 1, the A11, is donor specific. So presumably all the other antibodies will not react against your donor kidney, right? Because those antigens just aren't there. Okay. So this case was used to illustrate that. So as you can see, the recipient has these particular anti-HLA antibodies, okay? So if you look, they have an A2, they have a B27, a B44, etc. And if you look at her brother did have a B44, and she did not, so that's 1 donor-specific antibody. And the other loci we look at specifically is DR, and the brother did not have DR2 or DR8, so we're fine there. Okay, so here, and then you would go through each of the answers that way. And here, what I wanted to point out is that she her Luminex single antigen screen did have an A2 antibody, but because she does have the A2 antigen, one would consider that an autoantibody, and therefore it's unlikely to cause AMR. Okay? So what happens peri-transplant period? So this is when we're talking about doing the cross-matching. So here, what I want to get at is for a case for you to start thinking about how cross-matches occur and how to interpret it. But why don't we look at the case in more detail at the end after we've gone through the slides. So essentially, what really matters is what we call the allo cross-match, where you're examining the serum of your potential recipient or candidate against a single donor. Okay? Sometimes auto cross-matches will be performed, and that's essentially in some of your patients that have autoimmune disease, just to look at their degree of autoreactivity. Okay? Allo cross-matches are either done using the CDC assay, so the complement-dependent cytotoxicity, or the flow cross-match assay. Okay? One thing to remember is T cells express only class 1 HLA antigens, because class 1 is, as I mentioned, is on all nucleated cells, but class 2 is only on antigen-presenting cells, so we wouldn't expect them to be on the cell surface of the T cells. Whereas on B cells, we would expect the class 2, but because it's also a nucleated cell, one has to remember that you can also get class 1 expression on B cells. And sometimes, actually, class 1 is more upregulated on B cells than it is on T cells. Okay? So this is the general way that cross-matches are done. So you take your donor cell, and we split them up. So you do your T cell separately from your B cell assays. And that way you can get an idea of whether it's class 1, or you think it's class 2, or you think it's a combination of both. Okay? And with the CDC method, it's the same thing. You throw in the patient's serum. If they have alloantibody, you augment it with an anti-human globulin antibody, and then you add complement. And if there's evidence of donor-specific alloantibody, then you'll get cell death. Okay? In the method that uses flow cytometry, the main difference here is that you're not using complement. Okay? Rather, you're using a secondary antibody that's labeled with a fluorescent dye that just recognizes the patient's alloantibody, okay? And so in this flow cross-match method, you do not know whether this donor-specific antibody that a patient has fixes complement or not. All you know is that it's capable of binding to the donor cell. This slide is just to remind me to talk about there are other antibodies like medications that we give that when you do a flow cross-match, you could get a false positive. So for example, let's talk about rituximab, which we give our patients, not infrequently. So it binds to CD20, so obviously it'll bind to B cells. And then if you add on the secondary antibody, there's high likelihood that that secondary antibody will recognize this. So you could just simply be detecting rituximab being bound on the donor B cells rather than actual donor-specific anti-HLA antibody. And again, autoantibody in your autoimmune patients can also create false positives. And this just gives you the plot of actually how it looks like. So we compare the two different histogram plots, and the bottom panel would be where we would consider it positive, because there's a shift in the intensity of the fluorescence. Okay? So clinically, how do we utilize this? So the CDC cross-match, when the T-cell CDC cross-match is positive, that's an absolute contraindication to transplantation. And this is the seminal work that was done by Paul Terasaki, where he noted that if that was positive, then you would get hyperacute rejection, which we, don't ever see anymore because of this. A positive B-cell CDC cross-match, though, may be a relative contraindication to transplantation. A lot of it depends on the assay that's used in your tissue typing lab, because the assay itself is a little bit less reliable than than the T-cell CDC, and also because if you think that it's related to class 2, some people will transplant across a class 2 DSA. So this is center specific. I'll let you guys look into that in the interest of time. So a lot of centers will, actually the majority of centers these days simply do the flow cross-match and have sort of put the CDC cross-match to the wayside. A positive flow cross-match can be a contraindication, although one would argue that it's not an absolute contraindication to transplant, and this is dependent, again, as I said, on center policy. It does specifically identify IgG antibody, okay, and that's because the secondary fluorochrome conjugated is directed against IgG, okay. It's more sensitive than the CDC, so it really identifies a higher risk patient. And you may utilize it for considering desensitization therapies. Maybe you'll plasmapheresis these folks or even prior to transplant or around the time of transplant. Okay, I think I've already covered these issues. So getting back to PRA versus cross-match, I think the take-home message from this slide to remember is PRA is a general assessment of the degree and of anti-HLA antibodies that you have. So it's just thinking about it theoretically. Doesn't take into account which donor you're considering, okay? Whereas the cross-match itself is specific to the potential donor that you're looking at, okay? So PRA, general knowledge about your immunological risk, cross-match, absolutely specific to the donor. All right, so we'll try to get through this case. So this is a 60-year-old patient who's been on dialysis for 10 years. She's had 2 episodes of bacteremia because she dialyzes through a right-sided IJ catheter. She has multiple antibodies against class 1 and class 2 HLA antigens, and a live donor becomes available to her. She is known to have antibodies against her donor and against HLA-A2 antigen in particular. And when you go to do the cross-matches, her CDC cross-match is negative. However, the flow T and B cell cross-matches are positive. Okay. So which is the most correct? A, because the patient has DSA, this is an absolute contraindication because she will develop hyperacute rejection post-transplant. Well, as I said, if her CDC is negative, then that's not necessarily an absolute contraindication. Okay? So that's false. B, the flow cross-match is most likely to be false positive from the presence of an anti-IgM antibody and thus can be ignored. That's not true because we know that the flow cross-match is specifically looking at IgG antibody, so it's not a false positive. So that B is false. C, a negative cytotoxic cross-match means that the patient most likely has a non-HLA antibody that accounts for the positive flow cross-match. That's not true because we know that the flow cross-match is more sensitive, and I've already told you that by single antigen screening, the patient is known to have a donor-specific A2 antibody. And D, if the patient is transplanted, it's unlikely that she will experience hyperacute rejection, but has significant risk of having a later antibody-mediated rejection episode. And that's definitely the case because we know her, the more sensitive flow cross-match is positive, and we know already that she has donor-specific antibody. In terms of post-transplant monitoring, obviously a lot of centers monitor their HLA antibodies post-transplant, especially in patients that are high immunological risk. Either they're sensitized or they've had a prior episode of AMR. And essentially, we use this, we do post-transplant monitoring using the single antigen beads. And occasionally, we'll also do flow cross-matches, although that in part depends on whether it was a deceased donor, in which case sometimes you can't do flow cross-matches on a regular basis because you just don't have enough donor cells. Okay. So, I've covered the following points, hopefully, and I know it was a lot to digest in a quick 30-minute period. But if you have any questions, I'll be here at lunch, and I'll also be here for the next few hours if you want to grab me at the back.